board.
Okay. So
And we are good.
Thanks so much, Buddha. So I'm Jennifer Cory. I am the founder and the Chief Hope Facilitator for the Heart Initiative. The Heart Initiative is a community organized around education and support and resources and training for people with chronic disease, specifically cardiac disease. That's really where I'm starting because I'm a psychotherapist and I'm a specialist in the field of applied positive psychology and human flourishing and performance, but I also happen to be somebody who has ARVC. I was diagnosed 9 years ago. I collapsed in the middle of a long distance run, and as all of you who are on this site knows, my life was altered. The course that I was on became altered. And I decided after a period of time of really struggling with the changes that were happening, and not only was I diagnosed, but my sons were diagnosed as positive as well, both genetically positive and then one positive for penetrance of the disease as well. And I lost my mother as a result of a sudden cardiac event. So as anyone knows, this is really, it can spin your world out of control. But there was one sort of little part of me that remembered all the while that I was somebody who knew a lot about resilience and how to help people recover from really difficult events. I didn't know quite as much about chronic and ongoing challenges as one might face in a chronic illness or in something that's kind of, if you're going through a real degenerative cycle of something like I was early on. But I decided as soon as I could get my feet under me to sort of fill in the gaps in my own knowledge and then bring that back to this community that I care so deeply about. And because I knew something not only intellectually, but now I really understood it from the inside as well. So I'll tell you a little bit more about the Heart Initiative at the end, but part of what I wanted to do was the first year that I went to the Johns Hopkins conference, which I absolutely loved. It was about 2 years after my diagnosis, but honestly, when I left, my head was spinning. And when I spoke to some people this year and last year, at the end of the conference, you know, I would see them for dinner Saturday night or meet them and talk with them after the event and ask what they thought. And they said two things, well, three things always. One is, it was great to meet other people with ARVC. So if any of you are reluctant to come because you feel afraid and you think you might get overwhelmed with sad stories, it really isn't like that at all. So that's the first thing. People were overwhelmed with the joy of meeting other people and such positive people and people who really were working hard on understanding this disease and then optimizing their life. The second thing that they said is it was a lot of information, and that their their brain felt a little scrambled as a result of it. And the third is that they wish that they had some way to be able to sort of turn some of that information into very practical advice in their life. So I thought, well, I think that's an area I might be able to help people with, is synthesizing information to the best of the ability that I can do it myself, and definitely in helping people turn information into something practical and life-affirming and all of that. So we're not just walking away with a lot of knowledge, but we know how to be able to really apply that knowledge. That said, I have more slides than, as I almost always do, than we'll probably have time to cover, but I'm going to go through them and give you as much information as I can. For any of you who don't know, this is Hugh Calkins. He's the director of the ARVC program at Johns Hopkins, as he has been since maybe 1990 or in the early 90s. How did he become the director of this program, and how did we get so lucky to have Johns Hopkins as one of the premier programs for what was called at the time ARVD, arrhythmogenic right ventricular dysplasia, in the world? That was because of, first and foremost, the Campanella family. John Campanella, who you see pictured on the side here, his father was a professional NFL football player who died of a sudden cardiac event of unknown origin. And his family were really disturbed and concerned about that event, obviously. And but John was young at the time. I think he may have been a teen when his father passed away, but then in his 20s, his sister also died of a sudden cardiac event. Now, by that point, they had started to see this kind of chronic cardiac disease in young adults, these very intense arrhythmia diseases, and the studying around it had begun. I think the Campanellas went and met Frank Marcus in Arizona, and I'll tell you a little bit more about him as we go on. But Frank diagnosed him with this sort of budding diagnosis of ARVD, and then sent him, I think somebody's mic might be hot. Just take a quick check, because we're getting a little bit of feedback. And John came back and went to Johns Hopkins for evaluation and asked Hugh Calkins why would he be interested in starting a program specifically around the research of ARVD, which was this really sort of young disease diagnosis, and there wasn't a lot known about it. Jack Bogle was, and you know, to Hugh Calkins' credit, he sort of took that on and said he would be interested. Hugh Bogle was a man who was also diagnosed with ARVD. He was the founder of the Vanguard company. And so he also became very interested and was a contributor at Johns Hopkins, and also around the same time approached and said that he would be interested in helping to fund something like that. To help, he had had a number of significant cardiac events that he was revived from. And then eventually they found out that he had ARVD, and he was an early recipient of a heart transplant. Harold and Johanna Wilmerding, they lost a son to a sudden cardiac event, which was ultimately diagnosed as ARVD. And so the Wilmerdings and the Bogles were friends, and they became invested together in the Johns Hopkins organization. So between these three families, this is how we end up with the amazing program that we have at Johns Hopkins. Now, it's not these families alone that have continued to keep this program going. I mean, we all have to do our part to support this, because it's such powerful research and has been so incredibly helpful in really putting ARVD on the map, which we now call ARVC. And I'm sorry for playing with the names. We'll go back. I'll explain more when we get to the nomenclature part of this. But I think it's important to see what people were able to do, how they were able to transform, in the case of the Campanellas, not only their own loss and tragic event, but also their hope for John, and John being able to survive whatever this thing was that was sort of swallowing their family members. For Jack, who amazingly survived a number of serious cardiac events before he was diagnosed and received a heart transplant. And also for the Wilmerdings, that they were able to take their tragic loss, the loss of their son, and really wanting to turn it into something meaningful and powerful, and how many lives they've touched as a result of that. So one of the things that we did this year was to give a huge thanks to these founding families, and that included a honoring by Hugh and a plaque for them. So Hugh gave us the history of the program, which included the families and how the program started, and also what the primary goals of the program were 20 years ago. And that was to educate families and physicians about ARVD. And in fact, they've done that brilliantly. This disease is now recognized the world over. And if somebody has a sudden cardiac event, or sadly a sudden cardiac death, or a young person comes in with ventricular tachycardia or some kind of ventricular arrhythmias, one of the 5 things that they are immediately checked for is ARVD. And that's a tremendous turn in only a 20-year period to be able to make that kind of an impact in the world of medicine and diagnostics. The second thing was they wanted to help create diagnostic criteria and evaluation and management of patients. And just at Hopkins alone, they've worked with over 3,000 patients and families from around the world. And that has really, that kind of concentrated knowledge has really helped them to see all sorts of variations in ARVC and be able to really build on their knowledge of best practices. But the other thing they wanted to do was to add to the knowledge in the field itself about what this disease is and how to treat this disease across the board. And to that end, they've actually published 172 articles and studies. And today, when you do a Google search for ARVC today, when you do it, you get 500,000, it's actually 558,000 hits for ARVC. Now, I want you to just realize that in 1999 and 2000, in Google Scholar, you would get about 2,000 hits, meaning that there were about 2,000 references to this disease back in the early 2000s. compared to today, there are 55,000 scholarly articles found on Google Scholar. So from that perspective, I would say that Hopkins has really done their part and done an amazing job being leaders in the field of research in this area. The first hire after Hugh took over the directorship was Dr. Tandri. Dr. Tandri is an EP as well. And he is now co-director of the program. And man, he has brought so much incredible advancement in the treatment of ARVC to Johns Hopkins, and by doing so, really in the world. And then I think that the very first genetic hire was, geneticist was Crystal. She was a nurse there and also a geneticist. She became the first genetic counselor. Cindy is also a genetic counselor with an emphasis in research, and she's helped to co-author a number of papers and do quite a bit of research in the area of ARVC. They were both hired. Tandri came on in 2001, Crystal and Cindy in 2002, and Brittney in 2010. So this, with Dr. Calkins, makes up the foundation of the team at Johns Hopkins, although now there are dozens of other people there, faculty members, academicians, researchers, geneticists, and physicians who make up that team as well. But we're looking at the originals. And this was an original picture that Dr. Calkins shared from the year 2000. Here was the first ever meeting of, these were all the leading thinkers and great minds in the field of this arrhythmogenic disorder of the right ventricle, and here they are. I can't tell you who all these people are, but I know Frank Marcus is one of them, and if you look in the second row, you'll see Dr. Calkins with a lot of hair. The husband and wife physician from Greece are in this picture as well. I'm going to tell you a little bit more about them in just a moment. My apologies to anybody else that's in that picture who I don't know. So he went over, well, what have we accomplished in 20 years? Well, first and foremost, they created this website because they wanted this place on the web where people could come and get accurate information about ARVD. They have, to their credit, I don't know many other programs like this that are so dedicated to hosting annual patient seminars. And I think the reason that they do this is because this is an area of research that's really, and practice that's really been spearheaded by the patients themselves. And the way that this happened was a couple of patients heard that they were doing their first collaborative conference 20 years ago, and they came to Dr. Calkins. It's called Grand Rounds, and said, hey, we'd like to attend Grand Rounds. And he said, you can't attend Grand Rounds, you're not physicians. And they said, well, we want to know what you know. I mean, this is budding, you're just learning about it too, we want to know about it too. And to his credit, he was like, well, why don't we just tack on a patient day and have all the same people come and sit down and talk to the patients. And so that's been happening now for 20 years. So they've written a number of, as I said, chapters and books, and have reviewed articles, and have attended many lectures. And so the takeaway really from his lecture was, his presentation is, you know, now we understand the genetic and environmental factors of ARVC like never before. We're getting more and more information about that all the time. We understand the structural anomaly that's happening inside of the heart from a genetic perspective and muscle perspective. Hence the name change from ARVD, which was arrhythmogenic right ventricular dysplasia, to ARVC, which is arrhythmogenic right ventricular cardiomyopathy. But don't get too attached to that, because in a couple of slides from now, we're going to hear how that's changing too. They've identified many of the genes that are involved in what causes ARVC. They've done international collaboration all around the world, and they are one of 14 leading centers for research and treatment in the world. And they've helped to put ARVD on the map, quite literally. Brittney then presented on the primer of the ABCs of ARVDC. That's a lot of letters there. This is something that she does every year for new patients, but she's had a number of people who have had ARVC for a long time say that they would be interested in having sort of a review course. And so she, at least this year, integrated it into the conference itself. if anybody has heard Brittney talk, she makes me sound like I'm going slow, like at half speed. So she covers a lot of material in a very short period of time. And I'll just go over them really briefly. Here are some of the things that she said. A desmosome is really the glue between cells, and that's what we have, desmosomal disorders. Fibrosis is fat that infiltrates the heart, although one should know that everybody has some fat in their heart. In our case, it's fat that's replacing otherwise healthy cell structure when the cell breaks down. And it's where the fat sits in our heart that becomes problematic. It turns out that we know now ARVC can be left-sided as well. And so it's not only about the right ventricle, it can be left-sided too, which is why we're going to talk about another name change. It creates a delayed conduction across the heart, which is why it's an electrical problem. One of the things that they look for, they can look for structural damage, but that is not always easy to find, and you can't always get people to have reliable cardiac MRIs. So they look for T-waves inversions in V1, V2, V3, and in PVC, premature ventricular contraction burdens as well, meaning the more PVCs you have, everybody has some PVCs, but the more that you have, I think the number might be greater than 200 or 400 a day. That's when they start to really look, especially if there's family history. And yeah, it must be over 200 because my son, when he got under 200, they were really happy. So over 200 or 400. And that there's new genetic testing since 2012. So one of the biggest things that Brittney emphasized was if you were tested prior to 2012 and it was, you were diagnosed with an unspecified genetic mutation or no identifiable genetic mutation, she's asking that you be retested because the tests are much more sensitive now and they can cover a much wider range of genes. And another really big thing was, she said, we know now and can offer with complete confidence that pregnancy is okay. It is absolutely okay. It is not too much strain or stress on people's heart. She's more than happy, and many of the cardiac genetic counselors, I think there are not that many in the country right now, but the ones that are there are very happy to talk to people about the genetic implications of having a child with ARVC. I know that when one of my sons asked the doctor, well, Dr. Calkins, maybe I shouldn't have children, he, had all but threw his arms up and said, don't dare say that. Don't ever say that. He said, not only can we treat this disease and treat it well, he said, but in your lifetime, it's going to be cured. That's what he said to my son just a few years ago, which really made my heart happy. Notice the page that this is on. It's the background is Brittney's Twitter page. I'm not somebody who Twitters, but I did join, and I went on hers because she said that often when she finds new research and new articles, she puts links to it on her Twitter page. So for those of you who understand how to use Twitter, that's her address, @Murray, and then that lower underscore, I think it's called B-Dye, D-Y-E. And that's how you find her. And if I could find her, you can find her. And if you need my help doing that, minor Buddhist, please just let us know and we'll be happy to help you. So I'm excited to see they're having this international symposium yesterday and today. So they had 50 or 60 researchers from around the world come and do a medical conference together. And she's going to post a lot of the articles both on the ARVC webpage at Hopkins, but also through her Twitter account. So I didn't want to miss any of those articles. Here's my takeaway from Brittney's talk. She said, and a number of people there reiterated this, ARVC is 80% mental. That is not to say that you're making it up in your head by any stretch. It really talks about the relationship between the energy or the electrical centers of the mind and the heart and how deeply connected and embedded they are. And so the more stressed we are, the more erratic experience we're going to have in terms of arrhythmia and PVCs in our heart. So managing stress is a key to increased well-being with ARVC. And so finding and using strategies to navigate psychological and emotional components of this disease will make the difference between sort of dragging yourself through it and really being able to navigate with it in a much healthier way. So I like that she put up this stress cycle. One of the things she said is she has a low threshold for suggesting that people seek out a therapist or a psychologist, use anxiety reducing techniques and meditation and support resources. That's all the stuff that the Heart Initiative teaches, and it's the kind of support that we do and offer. And again, I'm happy to share more about that with anybody who would like the information. So we're already on that. I know without question what the relationship is between stress and the heart, and also how to be able to help people navigate that in a really successful and evidence-based way. There's a lot of research around how to be able to create better outcomes for yourself as a result of managing your psychological well-being in addition to your cardiac well-being. So the Naxos story, look at that absolutely gorgeous island. This is an island in Greece. And Adelina, here we go, Satsopoulou. Thanks, sorry, my bulldog is here, who's cute as can be. And a dog in the neighborhood just started barking. So my husband's coming to get my bulldog. But that gives me a chance to practice her name. Adelina Satsopoulou. Yeah, Adelina.
Hi, Jen. While we're waiting, I think there's a question from William. He asked, did anyone at the meeting discuss the NIH All of Us program, which offers whole genome sequencing for all participants? This program may ID more genes associated with ARVC and other causes of SCA. So if you have any inputs on that, then yeah.
To my knowledge, nobody talked about that. There was a presenter there who was talking about being able to see the entire genome sequence in small slices of, I think it was cellular makeup. Honestly, you'll see when we get to that slide, I have very little to say because I understood very little of it. But maybe somebody else who was there remembers it differently. If they do, you can, interrupt me and speak up, or maybe just put the answer in the, what's that, like the note area, the chat area? Chat area. Mm-hmm. So I'm just going to go over this really briefly, but the thing I was really...
I think William has something to say.
Yeah, hi, William.
Yes, hi, Jennifer. I was just going to say that the NIH had a meeting this morning where they went over the first year of results from their all-in-one research program. And basically, they've now signed up 230,000 people. And many of the people, they're from diverse backgrounds. Most of them don't have diseases, they're healthy. But there are some who have genetic diseases and many who have had heart diseases. And so they will be looking at the sequence of all these people that they have in the database. Their goal is to get over 1 million people.
Wow.
But they've only been at it for 1 year. And I signed up early and have yet to see any results, but I'm sure they'll be coming someday. But I just wanted to make people aware of that. And I thought perhaps they would have talked about it at the Baltimore conference, but I guess not.
They did not. We had 2 MD genetic doctors there, Dr. Dalmar and Peter, I can't think of his name, but we'll get to his slide in a few minutes. And they both talked about a tremendous amount of work being done over in genetics and the things that are happening there and how exciting, but both of them are doing their own original research in collaboration with Johns Hopkins and with Cindy James. So neither of them talked about the NIH program, but I'm really interested, and now I'm going to go look it up and get some information. So if I find out anything else about it, or if I have an opportunity to either reach out to Dr. Dalmar or Peter, the other physician, I'll certainly post that and let people know what the answer was.
Okay, I will send you, and also Heather asked, so I'll send you both some information on what the program is and how to sign up, and it's all on Facebook, so it's easy to find.
When you say on Facebook, you mean you can access it by Facebook, not on our Facebook page.
You can search on Facebook by just putting in NIH All of Us, and it'll pull up information on the program and the video from today.
That sounds absolutely amazing. Thank you. I can't wait to check it out. Thanks for sharing.
So, thank you for answering my question.
You're welcome. You're welcome. So Adelena and her husband Nikos were both physicians who were trained outside of Greece. And sorry. Maybe you take him downstairs. Sorry about that. So, but Nikos lived on this small island of Naxos growing up, and he always wanted to go back there and treat the people on that island as a physician. So he and Adelena moved back there, and during the course of their being there, a short period of time, he started to notice arrhythmias, first in one young man, ventricular arrhythmias, then in another, then in some family members. And here's where Naxos is in this, maybe it's Scilate Islands. So, I mean, it's the largest island of these islands, but you're talking about a pretty small and compressed area. And one of the things that he and his wife identified, was that there was this syndrome that seemed to go with this. So these right ventricular arrhythmias, coupled with this skin disorder and this hair that was just unusually coarse. And so he and his wife began to do this research and started to collaborate with other physician researchers around the world, discovered ARVC, which was then ARVD, sort of merged the understanding of these two fields and found this variant of ARVC that causes what's called now Naxos disease. And the takeaways for me is that at the end of the day, medicine can also be a love story, because she shared such a beautiful story about she and her husband and their passion for this and their lifelong pursuit of identifying and treating and, saving the lives of people in Greece, particularly around this group of islands who were identified with Naxos disease. That there are many faces of ARVC from a genetic composition perspective. And it's really interesting to see how they can manifest based on regions in the world. That this particular disease is limited to the Greek island, and that 1 in 1,000 people there are affected versus our 1 in 5,000 to 1 in 7,500. There's a lot of controversy about what that actual number is, but somewhere in there. Interestingly enough, now unfortunately her husband passed away, but notice the name here, Alex Protronotarios. This is a real test of my pronunciation skills. He is the son of this couple who also became a cardiologist and is a physician in London. And he came and talked to us about what's in a name. So, and why would the name of an illness continue to morph and change over time? And I didn't realize how fascinated I was going to be by this, but it turns out I was. He said language, especially diagnostically, should be specific. It should be easy to understand. It should be easy to use, and it should really help us to communicate effectively across disciplines. And I don't know if you noticed, but the disease that his father and mother identified, they did not name after themselves. They didn't even name it after the composition of the disease itself. They named it after the island, which again, I think shows their level of love and devotion of their people there. Because I think naming a disease after yourself is sort of how you create your legacy. And I think it's so interesting that they weren't interested in doing that. So he went on to say, we started with ARVD, that's because in the beginning we thought this was a dysplasia. That was our best educated guess about what was happening. Dysplasia is an abnormal growth of tissue. And then it was converted to ARVD/C because we started to understand the Italians actually came in. And there's a really strong regional component with Italy and a certain part of Italy and ARVD. And they said, well, wait a second, it's actually, we don't think it is a dysplasia. We think it's a cardiomyopathy, which means a breakdown of the muscle itself. And then sure enough, as we got more equipment and better understanding of this disease and more collaboration in understanding what this disease was, in fact, they were right. This was not a dysplasia, an abnormal growth of tissue. It was actually a breakdown of the muscle itself. that ARVDC has sort of been a gentle way of trying to move people, and I would say particularly the people at Hopkins, away from the word ARVD because, listen, at the end of the day, that's the name of their site, the ARVD.com. So I don't blame them. I wouldn't be too hot on changing it so quickly either until we're sure it's not going back. And because that was the name that they really started and published all their papers around. And so they started to use ARVD/C so as not to lose sort of the wide range of people who they had connected with around this disease and the ready identification of it. Now we've kind of moved more to ARVC. I think most people understand the D is really just a familiarity issue. It doesn't really accurately represent the disease anymore. But lo and behold, no sooner do we get comfortable with that when Alex says it's actually that RV is a problem now, because it turns out now the longer that we've studied it, the more people that we've met, the wider group of people, you know, that have been tested and studied over this period of time, it isn't just right ventricle. It's right and left ventricle. In different people, it presents in different ways. And there are a number of different variations of this disease. And so the real accurate word for it now, or language around it now, is arrhythmogenic cardiomyopathy, or either ACM or AC, which is how the language is starting to shift again. So this was a slide that he presented that I thought was pretty fascinating. I'm sorry it's so small and you can't read it, but I think that the blue lines represent like a hypertrophic cardiomyopathy, what they first started to identify with. And you can see then over time, the bottom line is years, over years, the number of hits that people were getting with that particular diagnosis. Then when it was diagnosed as ARVD, that's the second set of colors in there, green. You can see that number start to increase. This means not only familiarity with the disease, but with the language itself. ARVC is the yellow, and you see what happens there. All of a sudden, there's this big uptick in it, not just in the exposure to the disease itself, but also in people recognizing that name and using that more as the most familiar name for it. And then last but not least are the orange lines. That's ACM or AC. And so we can see how people are starting to shift to use that language. You are watching the ARVC drop down and the AC beginning to build up because it is the more accurate language. So what are my takeaways from that? Well, be flexible. Don't be too attached to your name, because it turns out it can change and morph and modify. That the changes have to do with advances in technology and increased knowledge, and that there are multiple forms of what are called atypical ARVC. So they've found enough of it now that it's not really accurate just to refer to it as RV anymore. Even people like myself with ARVC can convert over time to a bilateral cardiomyopathy. And so the name that they're leaning toward is this AC or ACM. Okay, here's the genetics of ARVC. I'm gonna touch on this stuff lightly because honestly, I struggled a little bit with it. I found it interesting, but I don't really know enough about genetics to feel like I'm fluent in anything about it. This is Peter Tintellen, and he is from the Netherlands. And he was doing so much cool collaboration with Cindy James and Johns Hopkins. One area of primary focus is in getting family members of a proband to be genetically screened. He does a lot of research about where does that start to fall off in the genetic line in families. So, and it depends in part on how people are diagnosed, which I think is understandable. So I think the more, sometimes maybe the more jarring the diagnosis, maybe the more siblings might be inclined to go then and be tested. But so there's the, not only how they identify family members, but the reluctance of family members to go forward. Which is one of the things that, you know, keeps the disease in a potentially, like a much higher level of danger to families, is when people are not willing to get tested and don't know what their risk level is. The other thing he does, though, is works in, and Bill, you'll find this interested in identifying new genes related to these arrhythmogenic cardiomyopathies. And you see in the upper left-hand corner, these are the absolute definitives. PKP2 is the most popular genetic variant, DSP, DSC2, right? all of these. And then you see strong variants, moderate variants, limited, the ones that they've completely eliminated, the cardiac genes that are absolutely not a part of ARVC or ACM, and then the disputed or refuted ones, the ones that they thought were, that now they are questioning. A new gene that was just diagnosed is what's called TJPI. And that's about all I have to say about that. Oh, that's not all that I have to say. The Netherlands have found one mutation called PLNR14 that is the only genetic variant right now that doesn't seem to be impacted in any way, shape, or form by exercise. It is only one. It's only found in the Netherlands. It does not give the rest of us permission to go out and become professional cyclists. But so far, they have found this one gene in arrhythmogenic cardiomyopathy that is not exercise related, and it is the first time that that's ever happened. So the work continues. Let's see, this was his conclusion slide. Room for improvement in the uptake of family members. That's in, getting them to come and be tested in order to prevent sudden cardiac death. And I think everything else we went over. So my takeaways for him were working to improve family screenings, newly diagnosed gene mutation, that there is one variant that's not exercise related, and that there are, if people have multiple variants, it seems that there is a more aggressive progression of the disease when you have a multiple variant.
Before we go on, I think Bill, you had something to say, did you?
I was just going to say that I appreciate seeing that slide, because I did find on it the one gene out of 60 that I've had tested that has had a mutation in it, and it's the MYBP3 or C3 gene.
Where did it fall on that list, Bill?
It's in the middle column. It says limited knowledge, MYBPC3. But it's a myosin binding protein that has a role in contraction of the heart muscle. Fortunately, it's the only problem I have that they found so far genetically. But that doesn't mean there's other genes that no one's looked at yet. It could be a problem.
Yeah.
But,
Bill, one of the things I would suggest, I'm sorry that I did this in the order of the conference itself versus the order in which I think things actually go, because it could be worth reaching out to Mario Delmar. I'm wondering if he would be open to that. I can't imagine he wouldn't. He's the other geneticist physician from NYU, and he was doing some fascinating research that I don't fully understand about the ways in which the genetic variants are impacting each other and then causing this sort of new variation of something. And he was at the cutting edge of that research, which was absolutely incredible. So I'll share one slide with him, because that was about everything that I thought I could contribute.
Okay, we can talk separately about it. Thank you.
I'm happy to. So then Dr. Calkins went through the management of ARVC. One of the definitive tests still remains cardiac MRIs, but he offered us a caution. And the caution is that it can also lead to a high level of misdiagnosis, false positives, because they are not read by experts in cardiac disease, looking specifically for arrhythmogenic diseases. And so they've had a number of people diagnoses they've reversed because of false positives. Also, the team at Hopkins, together with 14 other research centers, helped to put together what's called a risk stratification for sudden cardiac arrhythmias. And let me just see where that is. Yeah. I just want to see if there was anything else one of the things that he said about the reason for the misdiagnosis is because, as I said earlier, fibrosis does exist in the heart. So not every bit of evidence of fibrosis is evidence of ARVC. And so there needs to be some way of separating out what is just normal fat in the heart and what is fibrosis as the result of a cellular or desmosomal dysfunction. So here's the stratification calculator, the risk calculator that Johns Hopkins, along with these other 14 research centers, helped to put together, and it's accessible to anybody. If you go on to www.arvcrisk.com, you fill out this page to, I mean, one of the things you're supposed to know is the number of inverted T waves. I don't know if you know that. I don't know my number. But I think that part of that was being able to use this in conjunction with what your physician is offering as a result of the tests that they're doing to very accurately be able to determine the risk of your having cardiac arrhythmias, ventricular arrhythmias and tachycardias. Some of the things that they look at in this stratification are who you are in the order of diagnosis. So if you're the first family member, second, third, because the risk goes down with each additional person diagnosed. And that's typically because people are diagnosed earlier in the process as they go down the line. The number of PVCs, age, gender. One of the things that Dr. Calkins stressed is that men, and young men in particular, tend to do worse because of testosterone. And so gender is definitely considered a risk factor when gender and age are integrated together. The number of T-wave, where you are in your T-wave aversions, your ejection fraction, and again, I'm not sure if people know that, but I know that you can call your physician and get that information. And then at the end of the day, to be able to tally your risk factor as a result of that. He also talked about the use of subcutaneous ICDs versus transvenous ICDs, and the pros and cons of the subcutaneous. So there's less risk putting it in. The wire in the subcutaneous doesn't actually penetrate into the heart. It just sits very close to the heart. And one of the things he said, and it must be because people have asked, is the picture shows everything on the outside, but please understand it's under your skin. That's the meaning of subcutaneous. It doesn't actually sit outside of your body. So everything is under the skin, but what it's not is, it's not like mine is under the muscle and directly penetrated into the heart. So there are greater risks with that, obviously. Now, my takeaway, and I could be wrong about this, so anybody who heard it differently, I'm going to ask you to please comment. My takeaway was that they use the subcutaneous where it is a primary prevention for ventricular tachycardia in people who've never had it and have a lower risk of VT. So not in probands. I'm the proban in my family, meaning I'm the first person diagnosed, and I was diagnosed as a result of a sudden cardiac event, a VT. And so mine is transvenous, which I think was probably the only thing offered at the time. My lead goes directly into my heart. But for people where it's being used more preventatively, I think for younger people as well, because of the extent of the life that they're going to have to live with a device and leads, and so that they're not building up all of this debris inside of the cavity of the heart. So there are downsides with the subcutaneous. One of the things that he said is, so it sits above the heart, but very, very close to it and under the skin, but it has an increased risk of going off for the wrong reasons. Now, in people who have much less VT, in other words, people who aren't the proban and who are using this more as a prevention than an intervention, then this may not be a problem. But if you are somebody who is already having VT, this could be a problem of it going off too quick or not pacing enough. And also he talked about somebody's going off when they were doing yoga, specifically in down-facing dog, downward dog. So, you know, I think there are pluses and minuses to everything. Yeah, he was saying that the subcutaneous is really primarily for people without a history of a sudden cardiac arrest or ongoing VTs. So, the next thing was about the relationship between adrenaline and ARVC. Bob wants us to know that the subcutaneous also has a more powerful shock, he thinks, because it sits outside of the heart. I think you might be right about that, Bob. I get the feeling I heard that as well at some point. Now, remember that Dr. Tandri is talking about painless but he says it like this, meaning less painful shocks. And so I don't know if the subcutaneous has that capacity to create that initial, that early, what was it, like that smaller contraction of the heart, which then keeps people from feeling the same level of impact when a shock is actually delivered. So, but I agree with you, Bob. I think when I first heard about the subcutaneous, the shocks were going to be greater, but I do believe that they are either working on adjusting that or it's already been adjusted. I noticed a lot more talk this year about the relationship between psychological and emotional well-being and health and ARVC than I've ever heard before. I don't know if anybody else caught that too. I think they've touched lightly on it in years past, and this year I heard a number of people talk about it. So Dr. Calkins as well. They have done research specifically at the relationship between adrenaline and ARVC. In a study where people with VTs were given 3 minutes of high adrenaline IV or drugs. I don't know who signed up for that, but what they found were that their VTs went crazy as a result of that. The takeaway for us, I think, is looking at really understanding the emotional component of ARVC, and that it's great if we have the physical under control or somewhat under control, but if we're not simultaneously working on the emotional, then we're sort of, swimming upstream or against the tide in terms of our own physical well-being, cardiac well-being. And so again, as a psychotherapist, this to me sort of makes perfect sense, but it's taken a long time before I really have started to hear people talk about it as a matter of course in treatment for cardiac conditions. And it's good to hear, and it's important for us to hear. I don't know, other than offering breathing and some meditation techniques, if they have more to offer at this point in time, but there are programs that do. The mindfulness-based stress reduction is one of them. Yoga is a wonderful program for helping to align the body and the mind in a greater state of peace and less reactivity. The Heart Initiative teaches a whole series of evidence-based interventions to help people create better, higher levels of well-being and less stress reactivity. There are a lot of really good programs out there, and I think if you're not connected to or engaged with one, it might be time to rethink that part of your treatment. It's to me every bit as important as the medication you take and the ICD that you might be wearing. So he talked about risk stratification, the subcutaneous ICD, and the management of emotions in arrhythmogenic cardiomyopathy. The role of catheter ablation and sympathectomy was Dr. Tandri's talk. He, I think, is one of the most fascinating researchers and advocates that we have because of how cutting edge he is with what he does. I'm sorry about this picture because it actually shows them doing an ablation in the atrium, not the ventricle, but you guys get the point. It was a nice picture. He discussed the guidelines for VT ablation and when it's appropriate. One of the things that he said was you do not have to live this way in terms of lots of breakthrough VTs and difficulty managing symptoms that are really affecting the quality of your life. That the VT ablation that they're doing now at Hopkins is they've had no complications with whatsoever. And by complications, he made it clear that he wasn't talking about any kind of pericarditis or having to do it more than once, because those are both normal facets of having to do this procedure. He said, I'm trying to sort of electrically change something that is like a pinhead in an organ that's moving. And so, yeah, there's a chance that you don't always get it the first time. And that doesn't mean anything terrible. It means that we wait and watch and see how somebody's heart relaxes over time. And if it doesn't, we bring them back in and we do it again. But they haven't had any deleterious effects. They've had a tremendous amount of positive effects from people having the ablation done. The other thing that he talked about, especially in terms of improved quality of life, but then we also talked about sympathectomy. And if you guys haven't heard of that, it's where they cut a series of nerves. It's called the ganglia that runs from the brain to the heart. And it's been done since 1916, and for the last 20 years, they've been doing it for people with arrhythmias. It's called a neural modification. And it's, again, not without any risks whatsoever, but some of the risks were that it changed the ways that people sweat. It was causing a lot of sweating in the lower part of the body. In some people, it caused a mild eye droop in one eye, but they've actually found another way of going in that doesn't go anywhere near the nerves that affect the optic region at all. And so they've been able to completely work around that issue. And the people that it's good for, it's not a cure, but the people that it's good for tend to be young patients who have frequent and very fast VTs that are very often driven by adrenaline-driven events, anxiety, sexual engagement, doing something, like very active with a group of people. So for this particular group of people, it tends to be very effective. And I think they've been doing it at Johns Hopkins for about the last 3 or 4 years. Here's some of the history of the sympathetic denervation for anybody who was interested. It started, again, like I said, in 1916 when they were just doing one side. And they've been doing it now, bilateral sympathectomies, which is what they do to break the relationship between the way that the mind sends messages signaling into the heart, which causes the heart to begin to respond with anxiety as a result of an excitatory stimulation. So it doesn't mean that you sort of go dead and you don't feel anything good or happy, but it means that the brain does not send the same messages directly to the heart. Now, interestingly enough, they can't just cut the ganglia. I do remember, because I've researched this a little, they first started to clip them, probably not unlike what they did originally in vasectomies. Then they started to cut them and clip them. And what they found are the ganglia are so active that they would grow back over and over again. So now the only way they could do it is cut it and actually take the nerve itself out. And it's the only way that they can keep it from reconnecting or growing back. And again, according to Dr. Tandri, they've had a lot of success, but there's a specific patient population that they offer this to. Takeaways from him. The heart and the brain are hardwired to one another. The brain controls the excitability of the heart. Both the sympathetic and the denervation and the ablation are huge advances, but neither of them are cures, nor are they riskless procedures. Okay, exercise. I know that's what a lot of people are waiting for. So Cindy James, sorry I didn't put a picture of her on there. I just realized I forgot. When I was first diagnosed 9 years ago, and I had been a runner, and I had been somebody who loved to go to the gym, and I competed in triathlons. And what Dr. Calkins said, and at that time, was, it's time to go home and be a couch potato. I know that he did not mean that to be offensive, but I felt like somebody had stabbed me when he said it, because I had been anything other than that my whole life. And nothing about that felt easy or trite to me. And I've noticed in the last 10 years, there's been a lot of change in the way they talk to people about exercise and the way that they think about it. And I understand the caution early on. Their early research showed that exercise increased negative outcomes in this patient population. So now we know what to do, just no exercise. Now, as a psychotherapist, I know the relationship between exercise and psychological well-being. And so the idea of telling people, by the way, you have this chronic and really significant disease, and don't exercise at all. What the double impact of that would be on people's emotional states, which I think is why we see a lot of reduced quality of life outcomes in people with ARVC. Because for the most part, you're talking about people who are otherwise healthy and very functional, who all of a sudden have to abandon any kind of physical activity. So that's changed a lot now, and there's a lot of interesting research that Cynthia James and the gentleman from Australia are working on. I'll show his slides in a minute, so his name will come back to me, Andre Gerche. So one of the things that she suggests is, make sure you know what the American Heart Association recommendations are. One of the things that we do is we completely overestimate what we think is supposed to be normal or healthy exercise. And part of that is because we often have a mentality where well, I won't work out for 5 days, and then on the 6th day, I'll work myself for 2 hours, and that's how I'm going to make up for that. This is more, and I think everything relative to ARVC is about moderation and consistency over time and doing things really in moderation. She said, if the truth is, and she wasn't the only person who said that, Andre said it too, if you go back and look at the American Heart Association guidelines, it isn't for doing intense cardiac exercise. There are some people do it and can get away with it and you know, can do it well. But the truth of the matter is that that is not the recommendation. The recommendation, I think, is a maximum of 150 hours a week. 150 minutes. Yeah, 150 hours. That's my old self talking. 150 minutes a week, and to do moderate exercise and activity. So sitting. Oh, she was talking about the METs per hour of doing things like sitting, which is very low, walking, gardening, competitive cycling, and understanding what the METs are, and knowing what you can do and do as safely. Those with a mutation who did 3 times, so they actually did the research in this much detail, who did 3 times the American Heart Association recommendation for healthy adults who had the mutation, had 4 times the amount of arrhythmia than people who weren't doing 3 times. So I think that that's really fascinating. I mean, they've talked about intensity over time being an exacerbation, but when you actually look at it in this kind of research, if you do 3 times the AHA, the American Heart Association recommendation for healthy adults, you will have 4 times the amount of arrhythmia. So again, walking, gardening, dancing, biking, but biking slowly, or in my case, I've been exposed now to an electric bike and I'm in heaven. I absolutely love it. They even talked about, believe it or not, some occasional tennis. Now, I don't know. I personally, that might be more of a risk than I would be comfortable taking. But I'm somebody who's been shocked when I've been doing lesser levels of activity. And so I'm just not comfortable with that risk factor. But I think when they use the word occasional, what they're saying is if you did that once every 3 months, that's not going to advance your disease. But if you're doing it every week, and God forbid you're doing it every day, not only will it, but you'll experience then the effects of progressive heart disease and possibly heart failure. Occasional tennis, an occasional slow jog, Cindy was saying. And again, I've never heard them say this before. But I think part of what they're doing is as they get more research, they're trying to modify their recommendations to match the research. I do remember Hugh Calkins saying, listen, I know my patient population, and if I tell these people, meaning me, that they can bike, a couple of times a week, they're going to be out biking every day for 2 hours. And then they're going to wonder why it got worse. So I think some of it too is the fear that this is going to be misinterpreted by the type A's. And this is something that Andre Gerche was talking about. Just wanted to give you an example of what the METs per hour look like. So I don't know, I guess if you look at something like watering plants compared to surfing, surfing's kind of up there. But Cindy was saying, listen, if you were going on vacation and you wanted to surf, you could go surfing, but could you become a surf instructor? Should you be a competitive surfer? Should you be surfing every day? No, definitely not, because you can see the amount of energy that gets expended when you're surfing. But if you wanted to surf because you happen to be in Hawaii and you wanted to try it for a day or a weekend or something, that's a totally different story. I do understand the concern around moderation, especially with younger people who might not have experienced some of the impact of progression of the disease. And again, just her final word on this was that many of the benefits from exercise actually come with modest amount of exercise. And that seems to be a message that's gotten lost in our culture of extremism. No big surprise there. And by our culture, I don't mean the ARVC culture. I mean, the North American culture and probably the world, to be honest. So the takeaways were that ARVC is something that develops over time. The diagnosis is typically between 20 and 40 years of age. Intensity, type of exercise, and duration are what matter. Endurance sports such as cycling, running, basketball are the most damaging by far. And exercise, this was super interesting. The way testosterone plays a higher role in penetrance in men, exercise, it looks like, plays a higher role in penetrance in women, which is very interesting. Oh, Bob is correcting me and saying he thinks they were talking about doubles tennis. That would make sense, Bob. But I'm not a tennis player, so I don't really know a lot about it. But I think I'm sure that makes sense. But I don't think anybody here should take my word or Bob's or anybody else's for it. If you have a question, Crystal and Brittney are so open to answering any questions that we have, and you could certainly ask them in addition to your own physician. Here's going to be the shortest slide of all. Mario Delmar, I'm completely fascinated with what he does. I just don't understand it. So he is a geneticist and a physician who looks not only at the genetic variants that cause disease, and in our case, arrhythmogenic right ventricular cardiomyopathy, but he actually breaks down, I don't know, something in each cell structure to see what part of the gene is actually impacting what part of the disease. And then now what he's trying to do, Bob, to your point is, Bill, to your point is look at the way cells are interacting with each other to create almost like these unique fingerprints in each patient individually. I have a headache just talking about it now, but I do think that if anybody's interested in it, they should listen to his recording when it's made available. I understand somebody checked with Brittney and she said those recordings will be made available next week. All the recordings that I'm giving you this brief overview on will be available. So this is Mario Delmar. If you're interested, please listen to his lecture. I'm telling you, it was really fascinating. I just do not have the bandwidth to digest it and explain it in 24 hours. Maybe next week or the week after, but not today. So the takeaway from him, for me, there are a lot of brilliant people working on this disease. Lucky us. Does anybody have any questions? Because I don't mean to blow him off. Like I said, I've heard him speak before, and I think he's fascinating, and I am so grateful that he plays for my team. I mean, I can't tell you how grateful I am. I just can't really break down what he does in a way that I can easily both understand and explain to others. So if anybody has anything to contribute to that or any questions, please feel free to post them in the chat.
I think CC, I'm not sure, sorry, your full name, is trying to say, I think the point of Delmar's research was that we have been framing the disease of ARVC in a backwards or teleological way. He was pointing to how the research shows we have a discursive problem. So I think that's what she's trying to bring up.
A discursive problem?
Yes. We think everything hinges on the desmosome.
I'm sorry? Go ahead.
We think everything hinges on the desmosome.
Oh, yes, yeah. That's CC. That's exactly right. Yeah, and thank you for sharing that. Right. That in a way we're almost being too linearly focused. Like we're seeing this problem, we're sure it must be causing this, and he's doing much more of this. Like wait. You know, I don't think that the silo runs like that. I think that this story runs more across the board, and we have to be looking at it that way. Otherwise, remember that saying, like, if all you have is a hammer, everything looks like a nail? CC, thanks for awakening that. That is really what he was saying. I appreciate that clarification, that we're being way too linear in the way that we're looking at what the genetic relationship to this disease is. And by doing that, we're missing some really important facets, which is why he thinks the same genetic anomaly can cause right cardiomyopathy. Cardiomyopathy in some people and left in others and bilateral in others. And I encourage you to listen to his video. It's really, really interesting. This is Andre Gerche from Australia. And Andre's specialty is in elite athletes and their hearts. And the benefits of that level of intense competitive training and the deficits. And then, I don't remember quite how this came about, but he became interested in looking at exercise and ARVC. And he and Hugh Calkins have done some work, and Cindy James have done some work together here. So they've relied a lot on his research to extrapolate part of what they think is happening in patients with arrhythmogenic cardiomyopathy. I'm trying to teach myself to say it that way now, so I just say it at every opportunity. So one of the things that his research has yielded is that elite hearts, athletes' hearts, are 1.5 to 2 times bigger than normal hearts. The fitter you are, the bigger your heart gets. But one of the things that we know now is that exercise causes pressure in the right ventricle to go up. And if there is no place for that pressure to go, what will happen is that the right ventricle will actually start to deteriorate. And not only that, deteriorate, but also he showed the coolest video. So make sure you watch his talk too. He shows this really little snippet of video where under extreme athletic duress, like people who do ultra marathons or something, it starts, the right ventricle expands so much that it starts to contract in this really disordered and dysfunctioned way. And it pushes the septum all the way over to the left ventricle, and it actually significantly depletes the functioning of the left ventricle too. So it's kind of amazing that people have the capacity to withstand that level of damage, but it's temporary, but it can actually last for up to 24 hours, or maybe it was even longer after you're done exercising. So it was that level of sort of intricacy in his studies around hearts and athletes and what happens. He's the guy who puts people in the cardiac MRI laying down on their backs, well, as we all are, but then he puts their feet on a bike. He's created this little bike so that they're actually biking while they're in the MRI, so he can see in real time what's actually happening to the heart. Here were his tips for ARVC patients. Please understand that exercise can be a trigger for arrhythmias and can exacerbate this disease. His advising, based on all of the research he's done and has looked at how the heart reacts to stress and what happens to hearts that are damaged, especially in the right ventricle, is that it's intensity over time. And so if you are going to exercise, do two things. Make sure it's moderate and make sure that it's never for more than 25 minutes a day, 30 at most. Moderate exercise for the normal population is healthy and causes some gradual changes in the heart. But obviously for people who are dealing with a desmosomal, or Dr. Delmore might argue that, but who have the kind of anomaly that we have to be super conscious about not inflating the heart too much and not stressing it over time. Weight training is okay because it's something called a low hemodynamic factor, I think it was called, meaning it doesn't put the same kind of pressure on the heart. The reason they think that is because when you lift weights, you are actually creating a counter pressure in the heart. I don't know if you've lifted a weight, you hear yourself go like that, like you have to do a little bit of bearing down to actually lift something. Well, when you do that, it seems to have a counter pressure in the heart. And so now he's not suggesting you go out and lift 500 pounds of weight. He's saying if strength training is something that you're interested in and you can do it in a way that's mindful and moderate, there is not evidence that shows that that is a deteriorating factor on the heart. Two things that he's always having to warn athletes about, and he would say the same is true for people with ARVC, is not to drink excessively, especially not to drink excessively. And I don't think he means be drunk and exercise. I think he means be depleted from having drank too much and then exercise. I don't think anybody should be drinking heavily and exercising. And if you've been sick, the same thing is true. And he also referred to the American Heart Association guidelines. He said that if people would just reduce to the American Heart Association guidelines, he thinks that they would be able to exercise with more safety. So understand if you're a healthy versus at-risk athlete. The way that you know that, if you haven't been formally diagnosed, is if there's evidence of arrhythmias, if you've had any structural disease, family history. Be mindful of this time, intensity over time calculation. Understand that even short bursts of intense energy can trigger damage to the heart. Bob, to your point, probably full court tennis would fall into that category. And reduce to the American Heart Association guidelines. Weight training, as I said, is less hemodynamic impact on the heart. How am I doing on time, Buddha? I can't see my thing.
We're at 8:45 at this point.
Okay. Let's see. I'm almost at the end, so I think we can do it. If anybody wants to hang on, and if you can't hang on, you can come back and watch the video. But if you have any questions, I please ask you to put them in the chat box. I'll answer them even after you're gone, or somebody, I hope, on the call will do that. And then you can just watch the end of the video if you had to miss anything. So this is Frank Marcus. He talked about the history of ARVD. He was on sabbatical back in 1970 something, and spent a year in Paris and was invited to meet Dr. Fontaine and took him on rounds with him. And during these rounds, he met some of Dr. Fontaine's patients who had these young, healthy people with these arrhythmia disorders. And so their friendship and their professional collaboration began. This is a picture of Dr. Fontaine in the background. Unfortunately, he passed away last year. They together published the first paper ever on what would be then known as ARVD, right ventricular dysplasia, which was in 1982. And as a result of their work and collaboration, they identified 24 adult patients and wrote this paper about these patients. And that is really how our disease came to be known and understood and researched. And he just provided this little bit of a timeline of what happened from 1982 on. Obviously, a lot more happened, but I just thought I would share that slide with you. One of the things is he's an incredibly modest and very humble and lovely man, incredible, in addition to being brilliant. And Dr. Calkins asked us to all stand and recognize his enormous contribution of he and Dr. Fontaine to the discovery of ARVD and to the health and well-being of our own families as we've been able to identify and discover this disease and get treatment for it. He also helped to write and modify the 1994 task force for the criteria for ARVD. And so this was us giving him a standing ovation. And I think this is the last one, research directions. And Dr. Calkins wanted to remind everybody that this has really been a collaborative effort around the world, that they've worked with 14 academic centers throughout North America and Europe, especially most recently developing that the risk stratification calculator for sustained VT. And he's worked with research around the interplay between exercise and genetics with researchers all around the world, with patients and families from all around the world. And they're in the process now of launching the first ever clinical medication trial, a double-blind trial for cardiac disease. That's never happened before. And what they're doing is they're studying flecainide for the management of tachycardia in right ventricle. Here were the takeaways: that they've published 172 papers over 20 years. They've had this incredible interdisciplinary and international collaboration. They're presently now working on stem cell studies, the relationship between inflammation and arrhythmogenic cardiomyopathy. And they're doing medication studies and the subcutaneous ICD study. I just wanted to do a plug for supporting the program at Johns Hopkins. I was deeply humbled to see those families stand up and to really, for the first time, understand the history and how much my family has benefited. We've lost, but we have also gained a tremendous amount through being diagnosed with ARVC. And none of this would have happened, at least not at Johns Hopkins, not at an institute this fine. I don't think that the progression of the disease, understanding of this disease and treatment of it in the United States would have moved the way that it has had it not been for those gifts in the beginning. And they talked about, unfortunately, in Homedale last year or the year before, we lost a lacrosse player. Jack Dowd was his name, 16 years old. He died in the middle of a lacrosse game. Homedale is 5 miles from my house, and it was a devastating loss. As an example of what small groups of people can do in terms of wanting to support this program, the following year, this past year, they held a race in Jack's honor, and they raised a couple of $1,000, maybe it was $10,000 or $15,000, and sent it down to Johns Hopkins. We don't have to do $10,000 or $15,000, but if you can do $500, if you would consider putting them in your estate plan, if you feel like you have benefited from the work of Johns Hopkins, I think then we can do more than just be grateful in our own hearts or just to say thank you, but maybe we can all put a little bit of our money where our mouth is. And by the way, please know that they don't know I've asked this or I've said it. Nobody's put me up to it. It's just really my own thoughts about wanting to honor the work that they've done. So here's the team that, that came just to this year, this 20th anniversary alone. We have some of the best researchers in the world standing there on that stage. Andre, the back is Andre Gerche, Alex with a very long Greek last name, Peter from the Netherlands, Cindy James, Hugh Calkins, and Mario Delmar. And in the front row, obviously, Dr. Marcus Adelena and Cindy Sears, Adelena and her husband, Nikos, who discovered Naxos syndrome. And, you know, when I look at that group of people, I think, how did me and my family get so lucky? I'm sorry that we have a serious and life-threatening cardiac disease, but how did we get so lucky that this group of thought leaders and researchers and have thought enough of this disease and the families involved to come to something like this program, to dedicate their lives to doing this kind of research? I feel so humbled and so honored. I mean, every person on that stage has dedicated their professional lives to helping us. I'm not even sure I understand why that is, but I have nothing but the deepest gratitude for their efforts. And when I look at Dr. Marcus, you know, and having just lost Dr. Fontaine last year, they've spent their entire professional careers working on this disease. So 30 years before, long before there was even a name for it, 40 years ago. They're the ones that gave the name to it. That's, 40 years ago. That's incredible to stay with something so long and to dedicate your life to it. And when I went to Dr. Marcus to thank him, he teared up and said, "It has been my honor and my privilege." I was like, he took my breath away when he said it. And he said to see what's come out of it and to see the work that Hugh Calkins and his team has done have made every moment of his work here worthwhile. So, and I think every physician that was there, two of them came up and shared this with me after, said they were humbled to look out and see so many patients and families show up, to be so attentive and so interested in what was happening, to ask such thoughtful questions. And you know, a number of them said there should be more patient conferences like this. People have a right to this information. And one of them even joked and said, I think it was Dr. Delmar, and said, oh no, it was Dr. Gerche, said, "You guys put my medical colleagues to shame, because when I go to present there, who's on their cell phone, who's talking, who's getting up and walking in and out, all of you are in rapt attention here." Well, we know why, right? Because we're there as if our lives depend on it. And of course they do. So that's who was there. Here's the takeaway, how blessed I feel. Not that anything about living with arrhythmogenic cardiomyopathy is easy, but that we have so much support of the professionals of this caliber who care so deeply about this cause, and whose life work is not merely to help us live and live well, but to eradicate this illness in our lifetime. That's what every one of them said. So really, just last thing, and that's just a plug for what we're doing with the Heart Initiative. And we are starting a course on May 13th that will run for 8 weeks. We put a charge to the course only because Buddha and I have been at this building the Heart Initiative for a year, and started with a small grant, but everything else has come out of our own pockets. And so we're just trying to sort of put a little bit of money back into it. That said, anybody who couldn't afford it or needed some kind of financial help or needed a full scholarship would only have to ask, and we would make sure that that happened. So, but anyway, the course is based in the science of human flourishing, which is an area of study that I have trained in at the University of Pennsylvania. And I have 20 years of working in the field of mental health around cultivating resilience and well-being. And I've just taken all of that information, all of the science and research that's come out in the last 10 years in applied positive psychology, all of my own history in working with people in private practice, and created this 8-week course. Starts Monday the 13th from 7:30 to 9 o'clock. It'll run consecutive Mondays for 8 weeks, about 12 hours worth of online live training, except for Monday Memorial Day. And anybody who's interested in it, just let us know, and we'll share some information. You can always go on our Facebook page, which is the Heart Initiative on Facebook, and find out more information there. This is partly part of what the science of human flourishing looks like. It's like about having these, what I'll call buckets, and knowing how to be able to fill each one of them in ways that are evidence-based. And in doing so, to lift an entire sort of foundation of well-being in a way that allows you to have greater reserves of resilience for the undulating road that is chronic disease. So when you're not dealing with a chronic stressor, you can sort of live your life with lesser degree of well-being and resilience, because maybe you get knocked down every couple of years or so, and then you get up and dust off, and you do what I call revival of the underdog. You know, you rebound and get yourself up. If you're living with a chronic disease, this is a different story entirely, isn't it? And so you might face something every week. You might face it every couple of weeks. You might think everything's fine, and then all of a sudden have some period of significant health struggle or crisis. The way that I define living with a chronic disease is the way that they talked about Ginger Rogers and Fred Astaire. You know, Ginger did everything that Fred Astaire did except backwards and in heels. That's what life with a chronic disease is like. You know, it's not that where you can't live and live well. It's that there is this added challenge, this added difficulty that you wake up with every single day that nobody's going to know about looking from the outside, that makes you know, navigating life's twists and turns a little bit more challenging, or sometimes remarkably more challenging. And so if we can lift the foundation level of well-being by using all of these tools that exist in psychology and in applied positive psychology, I can't think of a group that would benefit more from that, from having a greater reserve of resilience. And so this is an image that I like, because I think it's lots of small changes, evidence-based changes that are integrated over time that can yield significant reward at the end of the day. So, oh my gosh, that's it. I just feel like I never stopped talking. I'm sorry about that, but okay, any questions? Anybody have any questions about anything? Guys, do you know how many slides we made it through? Like, I wouldn't tell Buddha how many I had, because he's horrified when he hears. Buddha, that was 68 slides. Buddha's like, Jen, you know, 1 hour, that's 30 slides, no more than 30 slides. I think he tries to get me to do 10 sometimes, but there was a lot of stuff to cover.
Yeah, we did go through a lot of things. I think, especially for me as well, when I was there last year and I wasn't here. I couldn't make it this year, but it seems like it's evolved. It's very evolved. It's kind of an evolving process in terms of both research and the kind of people who are attending as well.
Mm-hmm.
So yeah, it's really good to see the amount of work that they keep putting into this every year.
Agreed.
I'm going to quickly go through the chat boxes and see if there are questions. So William says, wonderful program at Hopkins for ARVC patients. Are you aware of similar programs for those with long QT, Brugata, and other heart conditions like idiopathic SCA?
I would suggest the SAD site, SADS, sudden arrhythmia, something.
I think it's sads.org, right? I think.
Yeah, sads.org. They're a really wonderful compendium of every other kind of rhythm and cardiac disorder you can think of. In fact, I'm going to be speaking at their national conference in Atlanta, Georgia in October. Did I say national? International conference. And so they'll have great speakers from around the world coming there as well. So if you're interested, please contact them and look at that schedule.
I've just posted the link as well to SAD, so in case someone wants to check it out, it's in the chat box. What else? Go through questions. Heather asks, what did you hear about the prevention and treatment of heart failure?
Sunshine. Hi, so good to see you. That within the program itself, they are working directly with heart failure experts at, I was going to say Mount Sinai, how awful, at Johns Hopkins, not that Mount Sinai is awful, but at Johns Hopkins. And one of the things I think you've probably heard Dr. Calkins make this recommendation before, if you've listened to any of the other talks he talks about, is they recommend ACE inhibitors for people with moderate cardiomyopathy, moderate to severe, because it helps with remodeling of the heart itself. And ACE inhibitors, I think, are they're considered a low-risk medication with some nuisance side effects, but nothing significantly dangerous. And so that has been their recommendation for the last few years. They did not add anything new to that.
Okay. I'm not sure if Cece is still here.
Well, we can answer the question, and then if she listens, or he, sorry.
Oh, I think the person is here anymore, but because she or he was mentioning a few things around our discussion earlier, which was the genes that are responsible. So I think she was mentioning about the genes that are interconnected, and there are other aspects that are affected, such as regulation of calcium that causes the muscle to contract and release.
Absolutely, yeah.
He also says that he believes ARVC is caused by multiple mutations as well. So
yeah,
it would have been great if CC could have shared if there was something else, but
let me just add something to that. I'm glad that CC again reminded me of something. I'm trying to remember if it was Peter from the Netherlands or Mario from NYU who was talking about it was Mario, Dr. Delmar, who was talking about the discovering this. It's not the uptake of calcium. It's the way that the calcium gets sent down into the heart following an uptake or something along those lines. I'm botching it, so I really encourage you to listen to the video. But it's one of the reasons that they're looking at flecainide as a very hopeful drug, because it's the way that they notice the cell structure interacts with the heart when there's a demand for something, and maybe it oversends calcium or it overfloods the heart or something like that. And it's a way in which flecainide works, particularly on that mechanism, that helps to mediate the way that calcium is. So I asked the question, well, does that mean that it's a calcium like a channel blocker? And he said, no, that's a different process in that chain of chemical mechanism. It happens at the back end of the chain. Again, this is Dr. Delmar talking, so I just nodded politely. But I trust what he's saying, which is it seems as though the research is showing that a drug like flecainide might be more effective. My own anecdotal story to share is that I was really struggling with medication for about 2 years, maybe even longer. And Dr. Tandri recommended flecainide. Lots of other people were really surprised by that and were even pushed back against it. But this was his recommendation because I went in to have an ablation done, and for reasons that aren't worth getting into, they weren't able to do it with me. And knock on wood, since I have taken the flecainide, I knocked in my dog thought out. Somebody was here. Even the flecainide has stabilized my arrhythmia remarkably. And so I would like to tell you, and I will tell you, that I think other things have happened too simultaneously. I started to do a lot of the work from an intervention perspective that I'm teaching to other people. And I know that that has helped from a psychological perspective, but I know that there's been a chemical shift for sure.
Okay, great. I've shared the link to the course page. I think both Heather and William had mentioned that it's been something that's been helpful for them. So maybe if any one of you think that it's going to be useful for you as well, do sign up. I've sent, the link is in the chat box right now. It's just course.heartinitiative.net. You'll be able to find out all the details, the topics that we're going to be covering, when we're going to be starting, and ways to register for it. I'm looking at any other questions.
Can we give David Linville the mic?
David, let's see if he's still around.
David, if you're here, can you just open your mic up?
Oh,
David,
there he is.
David, you're there. So his hand is raised. And, yeah, there you go. David.
We were just wondering, my wife and I were wondering, I take Sodalaw, and I was wondering, and I hate the Sodalaw, but is flecainide an alternative to the Sodalaw?
Well, I'm not a physician, David, but I can tell you that not all drugs have the same effect on everybody. Not all drugs, even if they're antiarrhythmics, so they fall into the same overarching category, but they're not necessarily in the same exact class. And I do know that they're in the middle of doing a flecainide study right now, and they are looking for people who are interested in exploring other medication possibilities, who maybe are not having the greatest experience with the antiarrhythmic that they're on. So
right.
You might want to speak to them about that, find out whether you'd be a candidate for flecainide.
Okay, I will. Thank you.
You're welcome. Thanks for asking.
Okay.
Oh, there's Duke, by the way, making his appearance. Okay, now you'll know who is barking.
Okay, I'm just going to quickly see if there are any other questions. I think there are a few comments. Again, it would have been great if CC was still around. Regina mentioned something about primary prevention. There is no prior history of VT. These do not have the capability of any type of therapy under the defibrillation. I think she's mentioning between the subcutaneous versus transvenous, I think.
Thanks, Regina. So I think you're saying, and put your mic on if you are inclined, but I think you're saying that if you have no history of VT or SVA, I mean a sudden cardiac arrest, SCA, that you would be a candidate for a subcutaneous. Is that right?
That's what I understood it to mean. I think that the sub-Q ICDs don't have any capability for pacing. So I think that was one of the criteria that you would not be a candidate if you needed any type of pacing.
Okay, thank you.
Sure.
Thanks for the clarification. Regina, is it okay if I tell people that you have more medical knowledge than I do?
Sure. I don't have much medical knowledge regarding electrophysiology. I'm a gastroenterology physician assistant, but yeah, I am a medical person.
So thank you. Thanks for sharing the clarification. So I would trust Regina's word on this, although I understand what you're saying with your caveat.
That's right.
Thanks, Regina.
Sure.
Thank you. I think that's more or less most of the questions. I think there's someone called B Roadside. I apologize, I don't know your name. She's just thanking us for the summary. Just got diagnosed and got an ICD in early April. 53 after having a very active lifestyle, whole life, just getting used to things. Great summary, looking forward to the videos. Grateful that I was able to work with the amazing team at Johns Hopkins. Thanks again for the online summary. Okay, so
wonderful.
A few thanks. I don't see any further questions. Unless anybody wants to ask any other questions, please feel free to do so now. I'm happy to unmute you or just unmute yourself.
Why don't you unmute everybody now? It's 9:08 and we'll thank you guys. I'm sorry for going over a few minutes, but I hope it was worthwhile in terms of the information you got. And I thank you so much for being here. Anybody has any questions, just jump in and ask them. Otherwise, we'll call this a night.
What about diet? Was there any mention about diet? Did that come up in any form, shape, or form?
None whatsoever, Larry. But let me just say this, and unfortunately, it's like Regina just jumped off, and she's the gastrointestinal doctor. But I will say this. There's definitely some correlation between the way we eat and bloating and the stomach becoming very full and that activating the vagus nerve, which can then activate PVCs and rhythm disturbances. And somebody actually asked me at the conference, he said, do you think that there's a relationship between like GERD or reflux and taking some of these meds? Because she said, I never did it until after I went on the meds. And ironically, I've asked myself the exact same question more than once. I never had an ounce of it. And I definitely, maybe it was the defibrillator, maybe it's the meds. I don't know what it is, but I've definitely had more stomach sensitivity in the last 9 years than, now maybe it's just my age. Maybe if I had none of this other stuff, people would say, lady, you're in your 50s worse. But I noticed it within weeks of coming out of the hospital. So that coincidental as that might be. Heather.
Because I notice if I eat too much and I'm sitting watching TV, I get very uncomfortable.
I can, Larry, I feel your pain and I totally relate. And if I get uncomfortable that way, I definitely get more PVCs and I get fluttery.
Yeah.
Sunshine, do you know if there's any relationship between, that's been researched between, like this and the activation of the vagus nerve and all of that?
I don't know for sure. It's logical what you're saying, but I don't know of research one way or another. And I'm sorry, I realized I wasn't muted while my dog was barking. I'm sorry.
That's quite all right. That's great. Yeah. And Larry, does that answer the question? I mean, it's an easy no, but at least we're validating your experience.
Yeah, no, absolutely. I just didn't know if anybody else had some of the same issues or concerns about what you're eating. I do at times. I try to eat healthy, but I don't know if there's any.
I definitely do.
Yeah. You can't see this, Larry, because you're on the phone, but other people are nodding as you're asking the question. And
Oh, okay.
doesn't it make sense that when you look at the relationship between the GI system and the heart and where they are, the proximity of those organs to one another, that if one gets activated, it may activate the other. So I think that makes perfect sense. And one of the key.
Well, you know,
go ahead.
I'm sorry. Go ahead.
No.
I was just going to say, one of the positive things about it is it reminds you, you know, not to overeat and eat sensibly and lighter, because that's what I started doing, and a good way not to put on weight.
I like your positive.
You're not overeating.
And that's the other thing is I was going to say to you about not eating 2 hours, within 2 or 3 hours of going to bed, and trying not to sit, you know, after you've eaten. I know these are hard things, but I can definitely the way that I am around. Okay, guys. If there's nothing else, then we will call it a night. Thanks for hanging in.
Thank you.
Thank you.
I'm sorry, Buddha?
Thank you.
I think William has something to say.
William.
No. I'm fine.
Saying
Thank
bye?
you.
All right. Okay. All right. Okay. Thank you so much for joining us.
Thank you, guys.
Thank you. Thank you. Appreciate
Thank
it.
you. Bye-bye.
Bye.
Buddha, I don't want to be the one to end the meeting for all in case you're still recording
Yeah.
things. Or whatever. So
That's
you
fine.
do.
I'll do that.
I'll just smile while you're doing it. Bye, David. Bye, PMK. Bye. Bye.
Okay.
You're still recording. Bye, everyone.